Welcome to my session online clinical class today. Today is a follow-up of my last lecture on lower GI bleeding. Okay, today I shall discuss a short clinical case scenario and followed by some question and answers on the case. Okay, what's the history of the patient? The patient is a 78-year-old man who was admitted for bleeding PR for a day. He passed out large quantity of bright red blood with clots. He felt dizzy and weak. There is no history of pain or altered bowel habits, no previous history of blood-stained stools or melena. There is no pain or vomiting. He gives a history of chronic left-sided pain, left-sided abdominal pain and difficulty passing motions with hard stools for many years, which improves with laxatives. Otherwise, no diarrhea or blood-stained stools before, and there's no loss of weight. He is a known case of hypertension and suffered a stroke 2 years ago and is now on Plavix 75 mg daily since then. He is a diabetic and on treatment with oral medication for the past 10 years. On examination, the patient was alert and comfortable with mild pallor, no jaundice and no pedal edema. His blood pressure was 100/60 millimeters of mercury, pulse rate 100 per minute, and the volume is poor. The arterial oxygen saturation is 96% on room air. The abdomen was soft and non-distended. No abnormalities were detected in the abdomen wall, and there was mild tenderness and guarding at the right lower quadrant. Otherwise, the rest of the abdomen was normal. No masses were palpable. The liver, spleen and kidneys were not enlarged. Digital rectal examination reveals a large amount of fresh blood and clots. No masses were felt and proctoscopy was not useful due to poor visibility. Okay, the clinical summary of this patient is as follows. The patient is a 78-year-old man who was admitted for bleeding PR for 1 day. He passed out large quantity of bright red blood with clots. He felt dizzy and weak. There is no history of pain or altered bowel habits before. He is a known case of hypertension and suffered a stroke 2 years ago and is now on Plavix 75 mg of clopidogrel daily for his disease. On examination, there was mild pallor, mild hypotension and tachycardia, but no pain, but mild tenderness and guarding was noted at the left iliac fossa. No masses were palpable and the kidney, spleen and liver are not palpable. Rectal examination revealed large amounts of bright red blood in the rectum. Now we come to the analysis of the symptoms and signs in this patient. History, the important features in the history is a 78-year-old man, it's an elderly man. He's got bleeding to a rectum for 1 day, short onset, large quantity and is bright red in color, fresh blood, associated with clots. He felt dizzy and weak. He passed history of stroke 2 years ago and is now on Plavix or clopidogrel for 75 mg a day. Okay, so these are the important positive features in the history of the patient. On examination, the BP was slightly low, 100/60, pulse rate was slightly high, 100 per minute, and poor volume. There's pallor, and there's tenderness and guarding at the left lower quadrant. And rectal examination revealed fresh blood and clots in the anal canal and rectum. Okay, these are the important signs that you elicited in examining the patient. And the diagnosis based on this history and examination, the clinical problem of this patient is bleeding lower GI bleeding, acute onset in an elderly 78-year-old man. And the possible diagnosis in this patient is bleeding diverticulum of the colon, angiodysplasia, carcinoma of the colon, especially rectosigmoid colon, and other diseases which lead to coagulopathy, such as the use of Plavix and colitis, either infective, radiation, or some other form of colitis. And from the examination of this patient, clinically the severity can be moderate in nature, okay, because he has got the vital signs altered, there's tenderness and guarding, and there's fresh blood, okay, and then he felt dizzy and weak. So these are all features of significant bleeding, and we classify him as moderate severity. Now the questions I'd like to pose to you to answer is question number 1. What is the significance of chronic left abdominal pain and constipation in this patient? The answer is diverticular disease of the colon. Okay, this diverticular disease of the colon, which is usually occurs in the left side, in the sigmoid colon. So the pain is in the left lower quadrant, left-sided abdominal pain. In the case of a patient with malignancy, you may not have this pain. Diverticular disease usually presents with mild pain in the left iliac fossa. Question number 2. There is mild tenderness in the left lower quadrant but no palpable mass. What is the significance of this finding? The answer is, it is probably an inflammatory lesion such as diverticulitis, and unlikely to be a tumor in which usually it is painless. And the mass is usually also non-tender. Question number 3. What is the most likely clinical diagnosis and other differential diagnosis? Bleeding diverticular disease or bleeding diverticulosis is the provisional diagnosis. Others include angiodysplasia of the colon, carcinoma of the colon, colitis, or coagulopathy due to Plavix. How will you assess the severity of the bleeding in this patient? For A, the answer is recording the amount, checking the amount of blood, the color of the blood, and frequency of bleeding. This is very important. In the history, the amount of bleeding should be documented in the patient. Then on checking, you look for pallor, which is moderately severe in this patient, and the blood pressure, vital signs, BP, pulse, which also indicate the severity of bleeding. Simple blood tests like hemoglobin and hematocrit are also important to detect the severity of the bleeding. Other clinical methods that can be used to assess the severity is using the Glasgow-Blatchford score and the Rockall score. Okay, the Glasgow-Blatchford score is a prediction scoring system using important clinical signs, a scoring system to determine whether the severity of the bleeding and the need for surgical or interventions. Okay, so that is Glasgow score, and then the Rockall score is a system to assess the severity and prognosis after the diagnosis is made on colonoscopy. For B, how will you interpret the vital signs, pulse rate, and BP in this patient? The patient is hypotensive, tachycardia, and mildly hypoxic. Okay, with the SpO2 of 60%, 96% on room air, is probably slightly hypoxic. These may be features of an impending hypovolemic shock, which should be carefully and aggressively treated in this patient. Now, question number 5A. What is the most useful diagnostic investigation for this patient? The answer, colonoscopy, biopsy, and if necessary, to carry out hemostasis. So this is a case where the colonoscopy is useful because it's not only diagnostic, it can also be therapeutic as well. So colonoscopy, biopsy with possible hemostatic interventions endoscopically as well. B. Describe briefly how this procedure is done, colonoscopy. Bowel preparation is given in the patient, and this is the day before, and the patient is asked to take low fiber diet for 2 days before that. The procedure is done under sedation. Patient is placed in the lateral position. Lubrication, very liberal lubrication of the scope is done before insertion, and the scope is gently inserted, maneuvering all the way to the cecum, and while look as you go along, you look at any changes all the way from the anal canal right until the cecum. And to facilitate the maneuver for vision, you have to inflate with air and suction, which is available and provided in the colonoscope. What are the complications of the procedure? Procedure of colonoscopy as shown here. The patient lies on the left lateral position, fully flexed, sedated, and attached to the various monitors to monitor the vital signs and the screen. Okay, here the surgeon inserting the scope through the anus after lubricating the instrument. Here it is the anus, rectum, sigmoid, descending and transverse, and the right colon are all visualized. From the anus, carefully the scope is maneuvered throughout the intestinal colon, the passage of the colon, from the rectum, rectosigmoid colon, then the descending colon, splenic flexure, transverse colon, hepatic flexure, and then you got the ascending colon and cecum. So all the way carefully inspection is done, flushing and suction used to distend the bowel and clear and provide a clear vision. And as you go along, watch for any abnormalities. If there are some abnormalities, then you can take a biopsy of the lesion that you see, and also at the same time you can do some procedures. If you see active bleeding, then you can do some hemostatic procedures using the colonoscopy. Now, what are the complications of colonoscopy? The complications can be related to the procedure, here as seen here, or related to the sedation. So, related to the procedure, bleeding due to trauma, injury and perforation of the colon, which are not very much rare these days, infection, some form of colitis, ablative or surgical procedures. When you do, you can cause massive bleeding or infection, and then incomplete examination. In a minority of patients, maybe less than 10% of patients, you may not be able to completely examine the patient, as the cecum may not be right, colon and cecum may not be viewed, easily viewed. So that in these patients, it is incomplete examination. This is another procedure failure as well. Then related to sedation, over sedation can lead to aspiration, respiratory depression, and so on. Okay, respiratory depression, and these are very dangerous for patients who are old, elderly patients with pre-morbid medical conditions such as COPD, cardiac problems, renal failures, and these are all important factors that can lead to severe complications. Okay. Question number 6. The pictures above are colonoscopy images of the sigmoid colon. You see here and here. What is your diagnosis? Okay, this is a bleeding diverticulum. See fresh blood coming out from the colon. This is the opening of the diverticulum, and here you see multiple diverticular openings, probably with a clot there, which suggests now it may not be actively bleeding. It's a suggestive of recent bleed. What is the subsequent treatment of the patient? Resuscitation, grading of the patient into severity, IV fluids and blood transfusion are the initial treatment. And once the patient is stable, you proceed on with the colonoscopy and other therapeutic processes that may be available, such as clipping, cauterization, or embolization. Next, followed by, if this fails, then you go to sigmoid colectomy, Hartmann's procedure, or delayed closure of the colostomy. Outline the principles of subsequent management of this patient. Okay, these are the IV fluids, close monitoring, HTU, patient in, output, oxygen, all these are important early treatment procedures. The bleeding stops, colonoscopy as soon as possible. If it doesn't stop, then you may go for a video endoscope. Okay. If the bleeding continues, you may do emergency colonoscopy, RBC TAC scan, angiogram, or embolization. If all these are not possible, then you may have to go for open surgery and colectomy. Okay, and this chart is manages the flow chart for the management of lower GI bleeding. Okay, first is clinical assessment, PR, and proctoscopy. The whole management can be classified under four stages: assessment of the patient, the scope. Next stage is the endoscopy, followed by investigations if necessary, then surgery if everything fails. Okay, so A, and this is a abbreviation we use: ASSIST, assessment, scope, investigation, surgery. Okay, so once you classify the patient into mild, moderate, or severe bleeding, especially life-threatening bleeding, massive bleeding. In mild bleeding, you have to wait most of the time. The bleeding is mild or stopped. Colonoscopy is the procedure to do. If it is positive, endoscopic treatment. If it doesn't fail, then you go for surgery. And surgery can be segmental resection, depends on the cause. If it's moderate bleeding, again colonoscopy is done. If it is negative, then you go for RBC scan or video endoscope, capsule endoscopy, VCE. And then if there is any lesion, you subject the patient to surgery. If the bleeding is massive and life-threatening, then colonoscopy will not be able to do colonoscopy as the patient may not be fit. So in these patients, you do a catheter angiography. Okay, and the most commonly done is CT angiogram or catheter angiogram if available. Otherwise, it's a CT angiogram. From there, you can see the positive findings. You can, and the bleeding has stopped, you can go for vasopressin or embolism. And if there's negative, no findings, there's no bleeding seen at the time because the bleeding is very much, the rate of bleeding is very slow, then you may go for other intraoperative procedures known as the intraoperative colonoscopy. And basing on these findings, you subject the patient to surgery, which can be segmental resection or total colectomy depending on the case. Okay, thank you for your patience and thank you for joining me in this short session. I hope this short session will help you to clear some of your doubts concerning the management of lower GI bleed. Thank you.